I will say two things. The first thing I'll say in terms of early relapse, my decision on early relapse isn't as much dependent on what I've done in frontline therapy. Okay. So if I know somebody who has high risk disease, they're going to get one KRD, like I said before, and they're going to get maintenance. And in my mind, the maintenance is going to be a PI plus lenalidomide. I do a double, at least a doublet, plus or minus dex if they can tolerate it. So when they're relapsing, they're already relapsing on a PI lenalidomide plus or minus dex. So that's a tough patient population. I have to think about that. In my mind, I try to put those patients on a clinical trial if I have one for those people. But if not, then I will actually choose a triplet regimen, and it will include a CD38 antibody. The CD38 antibody, because they haven't been exposed to CD38, and in the relapse setting, CD38 has been shown to work very well in that relapse setting. And then I choose a partner. So the partner could be carfilzomib in my mind. So right now approved is daratumumab, carfilzomib, and dexamethasone, or we can choose pomalidomide. So approved is daratumumab, pomalidomide, dex, but also isatuximab, the other CD38 antibody, pomalidomide, and dexamethasone. So I'll choose between one of those two. And if they for whatever reason had intolerance to the bortezomib and I couldn't keep them on that and they've been off bortezomib, then I'll definitely go with Dara KD. If they couldn't tolerate the Rev and they were only on bortezomib, then I'll go to basically ISA Pom Dex or Dara Pom Dex, one of those. So that's basically the first out of the gate is a CD38 antibody plus a next generation PI or an IMiD. And so I think those are really good combinations. I do think that, so we're also testing in clinical trials CAR T cells as part of first to third relapse. And in this setting, when they have high risk disease, I think that actually would be, you give them some induction, you collect their lymphocytes, you give them some bridging therapy, which would be one of those regimens I talked about, and then they get a CAR. And then we'll have to see whether maintenance after a CAR is needed in that scenario. I'll mention one other thing, and that is when people relapse, maybe they didn't have high risk disease when they first presented. When they relapse, I tend to do a bone marrow biopsy with FISH testing at relapse, especially first relapse, especially if it's a short first relapse, because I want to see, is this clone now a clone that's driven by one of these high risk abnormalities?